Welcome everybody, dear Chairman. My name is Václav Cholówko and I work in the Department of General Transplant and Liver Surgery at the Medical University of Warsaw in Poland, and I would like to present you a study entitled Risk Factors of the Undesirable Course for Laparoscopic Liver Resection During the Learning Curve, which was based on the Polish National Registry PIL mills. After years of pioneers in laparoscopic liver surgery, with the moment of establishing International Society for Laparoscopic Liver Surgeons, publishing first randomized controlled trials, and sharing experience through biannual meetings, laparoscopic liver resection significantly increased its popularity. However, diffusion of laparoscopic liver resection is not as fast as many of us would like it to be. Laparoscopic liver resection is a complex procedure with a need from surgeon of advanced laparoscopic skills, which mostly may be trained only during performing subsequent cases, preferably under experienced supervisor. It is the main reason why the learning curve is so steep. By most authors who studied learning curve in laparoscopic liver resections, major liver resections need around 50 cases to finish the learning curve, increase significantly surgeon's experience, and by that decrease intraoperative and postoperative complications. However, before that, it would be wise to know the situation when a surgeon may expect higher risk of undesirable course for his procedure before reaching the top of the learning curve. Due to this, we plan a study with the aim of assessment the risk factors for intraoperative adverse events and postoperative margin resection for laparoscopic liver resection during the learning curve. We have based on the data from National Registry PL Mills, which was started in June 2020. Data of laparoscopic liver resection performed in Poland was collected through RedCap software until the end of December 2020. There were 313 laparoscopic liver resections, and to the best of our knowledge, these were all cases performed in Poland since the beginning of laparoscopic liver resections in our country. Nowadays, there are 7 centers performing laparoscopic liver resections in Poland. After 2 pioneer centers, which start in 2010 and 2013, in 2017, following centers in Lublin, Białystok, Bydgoszcz, and Łódź has joined, what altogether made a significant increase in the number of cases performed per year in Poland. Among 313 cases, 234 were performed before reaching 50 cases for each surgeon. More than 90% of these cases were performed by 10 surgeons, of who only 3 have performed more than 50 cases. And the background experience among Polish laparoscopic liver surgeons differs, with the range of 4 to 26 years of laparoscopic surgical practice at the moment of performing their first laparoscopic liver resection. Also, the type of surgical experience useful for starting laparoscopic liver resection differed. However, it is worth to underline that their practical knowledge and training for laparoscopic liver resection was gained during plenty of courses and clinical visits to the well-known laparoscopic liver departments around the world. To assess the risk of undesirable course for laparoscopic liver resection, we decided to focus on intraoperative adverse events and positive margin resection. Intraoperative adverse events were classified in accordance to SATAVA grading. As potential risk factors, we assessed patients' BMI, history of previous abdominal surgery, and preoperative chemotherapy. Also, type and difficulty of the laparoscopic resection was evaluated. Data on operative time, blood loss, conversion, number of tumors, and maximum tumor diameter were collected. Additionally, we tried to assess the impact of type of surgeon's experience, creating arbitrary 3-grade scale for laparoscopic experience and liver surgery experience based on the number of cases performed per year. In accordance to that, we distinguish if the surgeon felt more experience in laparoscopy or in liver surgery. Most common type of liver resection were non-anatomical and minor liver resections. Almost 70% of included cases were classified as Group 1 in accordance to the Institute Mutualismo Sui difficulty classification. A vast majority of patients presented with solitary tumor with a median diameter of 30 millimeters. Only intraoperative adverse events grade 1 and 2 were observed in the study group, being reported in 70% of all cases. In the group of cases with intraoperative adverse events, more anatomical and anatomically major resections were observed. Control group differs from cases with intraoperative adverse events also in the difficulty classification, median maximum tumor diameter, and in surgeon's experience where liver surgery experience was lower than laparoscopic. Before performing multivariate regression analysis, we tried to assess the cutoff point for significantly increased risk based on the maximum tumor diameter, which was in chosen factors after univariate analysis. Analysis of the area under the receiving operative curve reveals 45 millimeters as the cutoff point for significantly increased risk of intraoperative adverse events. Moreover, diameter over 45 millimeters stayed the only independent risk factor after multivariate analysis. Passing to analysis of risk for positive margin resection, non-radical surgery was observed in 15.4% of cases. Comparing to control in positive margin group, intraoperative adverse events were observed more frequently, and surgeons declare more often lower liver surgery experience than laparoscopic experience. After univariate and multivariate regression analysis, lower liver surgery experience than laparoscopic experience of the surgeon was the only independent risk factor for positive margin resection in the study group. To conclude, surgeons who are starting to perform laparoscopic liver resections should be more aware of intraoperative adverse events in cases with larger tumors, especially over 45 millimeters. Additionally, high surgeon's experience related to open liver surgery may be more crucial in avoiding positive margin resection than high experience in laparoscopic surgery. Thank you very much for your attention.